Now, your pelvic floor is this bowl of muscles that you sit on, right? That holds up your bladder, holds up your rectum.
There is a particular age group that people are coming in where things just down there are not working as well anymore.
They are so valuable, and we don't really think about them until they become a problem. 1 in 3 women will experience leakage in their lifetime. When they become problematic, they can lead to a whole bunch of different issues. That can be constipation, that can be urinary urgency or frequency, like gotta go, gotta go. It can lead to back pain, it can be associated with hip pain.
So as women get into those perimenopausal and menopausal years, why don't you tell us a little bit about what we can do for our hormone health?
Our pelvic floor, it has receptors, estrogen receptors. Around average age of 51, her receptors are going to not get estrogen anymore. And so we do know that affects pelvic floor function. So women will develop more leakage. They will develop more pelvic floor weakness.
I am beyond thrilled to have one of the most trusted and relatable voices in pelvic health here today, Dr. Rena Malik. Rena Malik is a board-certified urologist, pelvic reconstructive surgeon, and certified menopause practitioner. She is the founder of her own private practice in California, where she treats pelvic floor dysfunction, incontinence, bladder pain, and more. She's published over 80 peer-reviewed papers and serves as an editor for leading urology journals. She's also a prolific medical educator with an online community of over 2 million subscribers. You've probably seen her on YouTube or Instagram, where she breaks down pelvic health myths and makes taboo topics more approachable. In this episode, we'll be talking about how pelvic floor dysfunction affects your core strength, stability, and everyday movement. From leaks to low back pain, we're getting into how these deep core muscles hold everything together. Okay, Reena, let's jump right into it. I am so happy to have you here.
I'm so happy to be here.
Thank you. And let's just talk about the pelvic floor. Let's get into it. I know that the pelvic floor is part of the core. I talk to my patients about this, but that's really hard for some people to grasp. They don't really usually think that. They usually think it's your abdominal muscles. It is so much more. So why don't you talk to me about how it's all connected?
Absolutely. So, I mean, you're like already at the top 5% of people because you know that it's part of your core. So the core muscles essentially include obviously your abdominals, your back, and your pelvic floor. Now, your pelvic floor is this bowl of muscles that you sit on, right? That holds up your bladder, holds up your rectum, holds up your sexual organs, right? So for women, it's your uterus and also surrounds your urethra and your vagina. And for men, it also surrounds the urethra and helps with sexual function. So it has so many facets. It sort of works every single day to give you support, to give you stability. So with every step you take, you're activating your pelvic floor. It also plays a role in urination and defecation. So when you urinate, you need to relax your muscles. Same thing with defecation. And it plays a role in sexual function. So when you orgasm or climax, your pelvic floor muscles are contracting. When you're leading up to orgasm, those pelvic floor muscles tend to contract and tighten and grow tension until you reach climax. And so ultimately they are so important for so many different things. And for women also during pregnancy, they're very valuable in helping support that growth of the baby or the fetus. And so they're so valuable, and we don't really think about them until they become a problem, right? So normally they're functioning all the time. We don't need to use any cognition or any sort of thought to make them fire. They're just working. But when they become problematic, they can lead to a whole bunch of different issues. And that can be things like urinary leakage, as you alluded to. That can be constipation. That can be urinary urgency or frequency, like gotta go, gotta go. It can lead to back pain. It can be associated with hip pain. It can lead to pain with orgasm or pain with sex or pain with ejaculation for men or pain with erections. And so they are so integral in so many things that we do and use on a regular basis. And so it's so important to talk about them and really understand when you might be having an issue and how to go about that.
Absolutely. And also, I have noticed for my patients that come to see me in my orthopedic practice, because I see all age groups, both genders, there is a particular age group that people are coming in where things just down there are not working as well anymore. So they'll often come to me with, I'm having groin pain, or when I sit or stand or lay down, things are uncomfortable. I'm sure they're coming to you for some other symptoms, but what are you prescribing to them to start with? I'm assuming it's PT, but tell me how your thought process goes and how you're talking your patients through treatment plans.
Yes, let's take a step back. I think before we do that, it's thinking about what's going on with the pelvic floor, right? So it can be weak or it can be tense. So when it's weak, right, that means that it's not tense, it's not supporting you well enough. So for women, they'll present with urinary incontinence. They may present, or that's leakage. They may present with feeling like something is falling out, like a prolapse. And so that is typically the common things that I will see. So it feels like their vagina is falling out. It feels like a tampon's falling out, something like that. That's typically the most common signs of a weak pelvic floor. And guys, it's so common. 1 in 3 women will experience leakage in their lifetime, right? And so it is really, really common. And so for those people, we typically want to strengthen the pelvic floor. We want to get those muscles working again. It can also be weak if you have neurologic conditions, if you're standing all the time, if you're someone who is a little bit overweight, that can affect the strength of your pelvic floor, anything where you're sort of using those muscles a lot. If you have like a chronic cough, or even some people who do really high intensity exercise, they can find themselves weakening their pelvic floor if they're not doing that correctly. And so in those patients, like I said, we want to focus on strengthening. So they'll hear things like do Kegels, right? Kegel exercises are just one type of pelvic floor exercises. You need to look at the whole picture, right? And you know this because you deal with the bones that are around those organs, right? Around those muscles. You need to make sure they're in alignment, that there's no injuries there, that there's no dysfunction there, that when you ambulate, you are sort of in alignment. And so it's not just doing Kegel exercises. That's why we recommend you see a pelvic floor physical therapist who can really assess the whole big picture and assess what exercises are going to be good for you. So that's one. Now, if they're tight or too tense, or we call high tone pelvic floor dysfunction, that's oftentimes where people have this tension and it's not relaxing. And I describe it as like a bicep muscle that won't relax, right? And so when you have your bicep muscle that won't relax, you can't go through a full range of motion, and you also can't, it hurts, right? It starts hurting in your bicep, but it might hurt in your elbow or your shoulder or your wrist even, right? So it's going to hurt in multiple areas, not just in the muscle. And so very similarly, when you have this high tone dysfunction, it will present in a variety of different ways, and it will present differently from person to person. So it may present with constipation. It may present with gotta go. You're urinating all the time during the day. You'll always know where all the bathrooms are. It can present with pain. So that can be pain with sex. That can be pain with orgasm. It can present with, a whole bunch of sort of different presentations. And so also, and lower back pain, as you mentioned. And so in those cases, we actually need to learn how to relax those muscles first. Kegels are actually going to make it worse. So you need to learn how to relax those muscles before you can then go and strengthen them. And so that does require some dedicated exercise. Anything that you want to do, strengthen or weaken, you think of it just like you're going to the gym. You need to do it consistently, and you need to give your body rest in between. And so for relaxation, again, I think it's very important to see a pelvic floor physical therapist, but I'll often recommend certain exercises for them to start with. So things like happy baby pose or child's pose or deep diaphragmatic breathing or like a really low, deep squat. All of those things are going to help strengthen and stretch those muscles. And then again, seeing a pelvic floor physical therapist, seeing a urologist or a gynecologist who's an expert in the pelvic floor who can help you sort of go through, figure out what the symptoms are that are the most bothersome. If they're constipation, it might be a GI doctor, but someone who's an expert in the pelvic floor and can help you sort of identify things to manage your symptoms and sort of help guide you in the process.
That's great. I didn't actually know that you could have too tight of a pelvis, and I didn't recognize that those were absolutely different exercises. And so I will definitely keep that in mind for my patients that I'm sending to PT. I do send to a pelvic PT, but I also send a regular PT also because a lot of times these things are all connected, right? So they're having some, hip pain or low back pain, and they think it's all focused on that. But, we know that these things are all interconnected. Is there any age group or demographic that's experiencing one over the other, the tight or the dysfunctional loose one?
The weak one is usually after childbirth, right? So if we're talking about women, it's most often after childbirth or those other risk factors we talked about, like people who stand a lot, who are on their feet all day, who cough a lot, who may be doing really heavy lifting all the time and not sort of breathing correctly. Those people are at higher risk for that weakness to occur. Now, and so usually it's after childbirth. So women usually in their, 30s, 40s and up. And if they don't get it treated, and it can continue to progress because those muscles will continue to be weak, right? And they're not going to, you're constantly urinating and defecating with weak muscles. In terms of the high tone pelvic floor, I don't think it's an age necessarily. It's usually a type of person. So the type of person who's experienced trauma, maybe they've had a type A personality and they're really anxious or stressed. It's just your body responding to those stressors, right? And it's a huge part of it. I think as doctors, I wish we had like a magic pill to take your stress away. I wish we had that, but it's like hard work, right? You got to really do the work to deal with the stressors. That's a huge part of it. But it's technically usually those people. And sometimes it's hard to say like what started what, right? Is it just the stress that started the pelvic floor dysfunction, or did you have pelvic floor dysfunction and then you got stressed dealing with it, right? But ultimately, we see that a lot, and you'll even see it in even young kids. So like kids who are, they're holding their pee all day because they don't want to use the toilet at school, or they're anxious kids, or we see it a lot in like nurses and hairdressers and people who don't urinate often. They'll start getting dysfunction because they're holding all the time. Or people who when we were younger, probably a lot of people would like really suck in their stomach a lot.
Yeah.
And that is also really bad for your muscles. And so your pelvic floor muscles. So you can
That's how you know we're an older millennial and Gen Xer, right? We were told to suck in.
I know. So I think that's really where you're seeing that some people have developed these behaviors that are actually hurting them.
Okay. So we talked a little bit, you touched on childbirth. So as women get into those perimenopausal and menopausal years, and I also want to touch on the men as well, because I'm assuming their hormones are also not in the same homeostasis as they were before.
Yeah.
Why don't you tell us a little bit about what we can do for our hormone health to help, keep things in the right place down there?
Absolutely. So when you think about our muscles, our pelvic floor, it has receptors, estrogen receptors, right? And so when you lose estrogen, which you do, every single woman is going to go through menopause around average age of 51, her receptors are going to not get estrogen anymore. And so we do know that affects pelvic floor function. So women will develop more leakage. They will develop more pelvic floor weakness. They will develop, sometimes more urgency and frequency because urinary symptoms, because there's also estrogen receptors in the bladder. Some women can actually get recurrent urinary tract infections because of the loss of estrogen, but also because of pelvic floor dysfunction. So sometimes, which I didn't mention before, but sometimes women will say, I always have this pain, like I feel like I'm getting a UTI. But in reality, all the cultures keep coming back negative. And it's actually because their pelvic floor is so tight that it's causing that burning pain when they urinate. And so that's another thing that we'll often see. So back to the hormones, I think that, ultimately replacing that estrogen, whether it's through vaginal preparations, which are very, very safe for almost every woman, unless she has like an active cancer, hormone sensitive cancer. Other than that, every woman can get them. They barely raise your systemic level of estrogen. They are very effective in terms of improving those symptoms, particularly the urgency and frequency urinary symptoms and the waking up at night to urinate. So that's what really we see the benefit in those people.
Okay. And let's move on to the men. Let's talk about them. What's going on as their testosterone levels are changing as they're getting older?
Yeah, so men's testosterone tends to decline with age, and we're seeing more and more low testosterone, which is basically a blood level test where we check for total testosterone, but they also have symptoms. And symptoms are often low sex drive, maybe getting less strong erections, particularly at night, having mood changes, so maybe depression, having cognitive difficulty with focus, so brain fog. And then, so all these symptoms, and loss of muscle mass. So they might be going to the gym and they've been doing the same routine forever, and they're just not getting as much muscle growth as they
Welcome
used to.
To how women feel,
exactly.
By the way.
Same thing. So it's very similar.
Yeah.
So they're having these symptoms, plus their testosterone is declining. So their testosterone level may be declining. The amount of free testosterone in their blood level will be lower, but also their receptors are getting less sensitive. So even though they may be seeing the same amount of testosterone, their receptors are not as strong. And so in those cases, when we see these clinically significant symptoms plus the levels, then we know that giving testosterone shows so much improvement in terms of gaining muscle mass, in terms of mood. So we see improvements in depression, them needing less high levels of antidepressants so they can actually reduce their dose sometimes. We're seeing improvement in obviously libido, and we're seeing improvement in nighttime erections. I think the one thing that people think often is that, oh, if I take testosterone, my erections will completely be normal again if you're having some trouble there. And the fact is that while it's a part of your erectile function, it's not the whole thing. And so sometimes, yes, you will see improvements, but not everybody will.
Okay, that makes sense. So let's get into how you counsel your patients. You talked about PT, we've talked about hormones. What role are you talking to your patients about exercise, weightlifting, cardio? We obviously know it has great cardiovascular benefits and great benefits for your musculoskeletal syndrome. But tell me in your field how you're counseling your patients about that.
Yeah. So what we say in sexual medicine is what's good for your genitals is good for what's good for your heart is good for your genitals. What's good for your brain and your heart is good for your genitals, because it's a lot of the dysfunctions that we see with sexual function. For men, it's erectile dysfunction. For women, sometimes arousal disorder. Those issues are because of lack of blood flow. And so lack of blood flow happens as you age, as you get worse cardiovascular, your blood vessels are not as healthy and so when your blood vessels are not as healthy, the first place you're going to see problems is in your genitals, long before you get heart disease, because the vessels are so much smaller. And so anything that's good for your heart is good for your genitals. So I'll give you an example. When you exercise 150 minutes a week, so aerobic exercise, 150 minutes, moderate intensity, you're going to see a significant improvement for men in erectile function, as good as what you would get with taking sildenafil or Viagra.
Wow.
So literally you are not only improving your sexual function, but you're reversing the problem, right? So you're making your blood vessels more healthy. And the same applies for women. When you include exercise, you see women's sexual function improve. And the way I like to describe it is that when you think about erectile tissue in men, people are very familiar. You can see a penis get erect, right? Women's clitoris is the exact same tissue. It's a homologue, right? And so when we think about women having arousal disorder, it's because of losing blood flow to the clitoris. So maybe they're having more trouble with orgasms. Maybe they're not feeling as aroused when they're with their partner. And it's because, again, a lack of blood flow. And so there's much less research in the women's sexual health area, but ultimately, the idea is the same. They're literally identical structures. If you cut them in a cross-section anatomy lab, they look exactly the same, and they're formed from the exact same tissues. So I think ultimately, yes, cardiovascular exercise is great for blood flow. Now, resistance exercise is really good for muscle building, which is really important for testosterone. And women need testosterone too. So both men and women need testosterone. Women don't realize this, but they have more testosterone in their bodies than they do estrogen. And testosterone is the hormone of desire. So when you're having low libido, or you're just not into sex as much as you used to, some part of it could be that your testosterone's also declined. And so doing resistance exercise, particularly the larger muscle groups, is going to help improve your testosterone naturally.
So you mentioned blood flow. So now I have to ask this question. What's the role of regenerative medicine in your field? Because as you know, in orthopedics, it's talked about, you see the athletes out there getting platelet-rich plasma and stem cells in tendons, Achilles tendon, rotator cuff, to kind of beef that up, give it a boost.
Yeah.
And it depends on blood flow. You can't really inject places that don't have good blood flow. It doesn't have a bed to be able to do anything. Right. So what's that role in your field?
Yes. So I love that question, because it is evolving, and we're seeing more and more of it. So we see it again so far more in men's health. Hopefully we will see improvements in women's health. There are some studies ongoing, but there's 3 main regenerative therapies that are ongoing right now: shockwave, PRP, and PRP injections, as well as stem cell therapy. I would add that there's some really early preliminary research on hyperbaric oxygen, but ultimately shockwave, we've been doing research on shockwave for like 10 plus years, over a decade, and it's been shown to improve, again, with guys who only for vascular dysfunction for erectile issues. So 70% of guys with ED due to medical problems, not psychological problems, they will have blood flow issues. So the large majority of guys are not getting erections because blood flow is not getting to the penis. And so in those patients, shockwave can help because it's essentially sending sound waves to the tissues, which creates these mechanical trauma. Your body says, hey, something's wrong here. Let me send in some growth factors. Let me send in some stem cells to sort of regrow that tissue. And so it's reversing the problem, right? It's fixing, it's remodeling the tissues. And so that's great because all the other things we have are just Band-Aids, right? They're just like, if I give you medication, it's a Band-Aid. It's not reversing the problem. And so that's great. It's still experimental, but I suspect very soon it will be in the guidelines. It's in the guidelines for the Europeans. It's in their guidelines for management of erectile dysfunction. I think very soon it will also be in the US guidelines, so the AUA and SMSNA guidelines. PRP, the data is mixed for erectile function. It's been shown in some randomized controlled trials to be beneficial. The newest randomized controlled trial out of Miami didn't show any benefit. So I think it's still up in the air. And stem cells ultimately are really early in terms of data. We don't know which type of stem cell, the amount of stem cells, that sort of stuff. And so I would say, again, still very early. So I think I'm excited that we're looking at this stuff, and I think it's going to be really great for the future as we find more things to improve sexual health and apply them to women as well. And so, there's been some studies looking at shockwave, for example, for pelvic floor dysfunction, because it helps with blood flow to the pelvic floor muscles. And so a variety of different things. And I think, it's exciting.
Yeah, it is very exciting in my field as well. So that's great that we can get people help that way.
Yeah.
What other tools or alternative therapies, like for instance, acupuncture, or other kinds of tools we've heard of vaginal weights. What are your, I know. What are your thoughts on all of these other kinds of alternative therapies? Because you know that when a patient is coming to see you, they've tried a few things and they're probably at their wits' end and they've tried some of these things.
Yeah.
And I know not everything, obviously we're evidence-based, but what I've noticed in my own practice is I sometimes give some credit to some of these alternative therapies that I can't really explain why they're working, but they do. And I do share those with my patients.
Yeah. I mean, so it depends on which issue you're talking about. So we can start with just sexual dysfunction as a whole. A lot of people will use, there's so many supplements out there. And I've actually done a deep dive on many, many supplements. And I will say that very few have robust data to support their use. And of course, they're not regulated. When I talk to men who have erectile dysfunction, they really want to try a supplement, I would only recommend things like L-arginine, L-carnitine, or L-citrulline, which are all precursors to nitric oxide. And so nitric oxide is essentially the ignition for erections, the ignition for arousal, right? And so if you are struggling and you really want to try something, that's the one I would say that has the most research on it. In terms of other things, vaginal weights, I do not recommend. Okay. Douching, I do not recommend. So vaginal weights, think about it, right? It's just like as if you were going to go to the gym and you were just going to hold a weight for hours and hours. It's not going to give you any hypertrophy. It's not going to actually strengthen the muscles in an efficient way, right? So it's actually not beneficial even for your pelvic floor. The best thing is to actually do a contraction, right? Contract and relax. That's how you're going to actually grow those muscles. In terms of the thing that I think, actually helps a lot is vibration. So vibration, there's tons of data on how vibration improves blood flow to the genitals and helps have more intense and stronger orgasms. And there's a reason for it. That vibration is creating more blood flow to the genitals. And so that can be really beneficial for people, both men and women, to use to help stimulate their genitals. And it can be fun. I think people forget, sex is supposed to be fun. So bring toys into the bedroom. Try different things. And that's honestly the best way to improve sexual function. Improve novelty, cultivate desire. It's not just, we're just going to have sex. It's right now. You should be, foreplay starts in the morning. You should be having foreplay with your partner early in the day. You should be sending sexy text messages or other stuff, right? Just try to cultivate that desire for yourselves. That's going to really enhance your sex life. Now, in terms of other areas, I would say for recurrent UTIs, there's some reasonable data on cranberry supplements that actually can reduce the risk of recurrent UTIs. I think those are the big ones. In terms of acupuncture, we do a procedure that's very similar to acupuncture for overactive bladder called PTNS. It's posterior tibial nerve stimulation, because that nerve then travels up to the sacral nerve root, which innervates the bladder and can improve overactivity of the bladder. And so there is some cool stuff that we offer for people who are not doing well with lifestyle changes, medications. We have things like acupuncture that we do.
So you touched on this yourself, actually. You mentioned, how sex should be fun and the foreplay should start early. So tell me about the other members of your healthcare team, right? You mentioned pelvic PT. Obviously you're the urologist for them. Who else are you conversing with? Are you offering services where they're seeing, a psychologist, couples counseling? What role does that all play?
Yeah, so usually we'll refer to a sex therapist. And so there's a website online, asec.org, where you can find a certified sex therapist near you. And I can't tell you how great these people are, right? It's a great way to talk about sex, especially because we're not taught how to talk about sex,
Not
right?
at all.
So
Yeah.
you might be with your partner for 20, 30 years and you've never had a conversation about sex. Like, how do you start that, right? And I usually give my patients tips, but ultimately sometimes it's great to have a person with you to have that conversation, right? Because a lot of times when you have a problem with sex, that's all you're thinking about. So when you're with your partner and you want to finally start having sex, you're like, for a guy, it might be, am I going to have an erection? For a woman, it might be, am I going to climax? Whatever it is, right? You're thinking about it, you're ruminating on it, then you can't really be mindful in the moment. So mindfulness actually has been shown significantly to improve desire for sex. So for example, in a study, they had women do mindfulness exercise for 20 minutes outside the bedroom, 20 minutes of mindfulness every single day. And they saw significant improvements in desire as well as orgasmic function and arousal. So many different areas of sexual health improved just because of mindfulness. And so think about it when you're with your partner and you're like, oh, I have so many things to do. Like, I'm not in the right headspace for it. You have to like let things go and enjoy play, right? And be with your partner and not take it so seriously. And so there's such a role for being able to talk about sex, even as simple as being like, hey, what do you like that I do? Like making it very like casual. I often tell people to have conversations when you're not looking straight at each other. So like when you're out for a walk or when you are in the car so that you can like talk and like you can have a reaction, but they don't have to see it. And so, yeah, I think it's so valuable to start having those conversations. And it's not just one, right? It's going to be multiple conversations. And that's where it becomes magical because you're like, oh, now we can finally be open with what we like. And I can tell you what I like and you can tell me what you like. And we can really go there and we can try and experiment and do new things.
I mean, that sounds like quite the psychological shift.
Yeah.
Not just about your body, but sort of in your brain as well. So do you feel like mindfulness is different than breath work? Because I know there's a lot of breath work in relaxing the pelvis as well.
Yeah. So I think, any sort of diaphragmatic breathing, right? You're going to relax the pelvic floor. And so interesting when you think about sex, right? In order to have, for example, to get aroused, you need parasympathetic nervous system to be activated, which is your rest and relaxation. So you can absolutely sort of like activate that with deep breathing, right? And so that can help you get more sort of in the zone to be able to get blood flow down into the genitals, right? And then, so that's sort of like where, we think about it when you're about to climax, that's when your sympathetic nervous system starts revving up and you're breathing heavily and you're like, you're getting really like excitable. So if you can sort of tampen that down, you can sort of like relax into the pleasure, right? And just really be in the moment.
Well, you have given us so much useful information today, a lot of which is completely new to me, but I do feel like I get a subset of patients. I think it's usually women and it's after they've had kids and nothing feels right down there.
Yeah.
And so this has been useful to me and I can see all the crossovers with different specialties in medicine. I want to shift gears one last time and because I would be remiss not to talk about how you're a South Asian female in urology. Can we talk a little bit about how many of you are there in urology? And you also own your own private practice, which is also something different. And it's something I'm passionate about, seeing women do that, for themselves and for medicine in general. So talk about that path a little bit.
Yeah. So, it's interesting. There's only 11% of practicing urologists who are women. And when I started, it was like 8% or even less. And so there's not a lot of female urologists. And so going into urology, I sort of probably similar to you, liked surgery and was like, okay, what subspecialty do I like? And like, just loved urology, just loved the different kinds of like surgeries we did. The people are great. Like, how seriously can you take yourself when you're dealing with genitals all day? Like, just not that seriously. And so I took a chance to go into urology and fortunately had a really good experience in terms of like, being treated very well. I was pregnant twice during residency and had good experiences, had supportive mentors. It is very different being in a male dominated field. You have to sort of realize that you're going to be the one, right? I was lucky. We had 3 women at a time in my residency, but there's very often one female if you're lucky. You might be the only female in your practice. You might be the only female in your residency. And I think that the big thing is that we take care of patients differently, right?
Yes,
and so,
for sure.
Like we see, for example, in urology, we see all the women with recurrent UTIs, and getting a woman undressed and redressed for an exam takes extra time, right?
Yes.
And so like just that basic thing alone, and forget about anyone comes in with a pelvic floor disorder. It's usually not just that they're leaking. It's usually they're leaking and they might have a little bit of prolapse, and they also might have some recurrent UTI. So you're dealing with multiple issues because the pelvic floor manages so many things. And so it just takes longer. And so understanding the value of what we bring to medicine is always a little bit of a challenge. And I think, I think it's just something you have to be willing to advocate for yourself for, and have people see the value in you and educate them on what that is. But it is harder, right? I think in general, it's just harder. And I think just delivering care in this atmosphere of insurance reimbursements is very difficult. I mean, you can't do right by your patients in 15 minutes, which is what
it's just not possible.
It's not possible to really educate your patients. And we tend to take longer with our patients. It's actually in the studies that women tend to take longer with their patients, but they tend to have better outcomes. And so, it's like, what are you paying for? You're just paying for getting people through an assembly line, or are you actually paying for outcomes, right? Which we've stopped. We're not doing anymore.
I know it's really sad. And honestly, you could make the argument on the patient side. I'm sure females feel more comfortable with you, but even the men who probably don't want to talk about some of these things with another male physician, I would suspect that there's a subset that feel more comfortable talking to you.
Absolutely. I mean, a lot of my patients, obviously they find me because I'm a female, but they come to me, saying, I would much rather talk to you about this than feel like I'm being judged by a male, right? Because I'm having a dysfunction.
Yeah. Well, I love the work that you're doing. I love your education online. I'm super passionate about especially women starting their own private practice and taking medicine back in that way. So thank you so much for being here today. Can you tell our listeners where they can find you? I know there's a number of places.
Absolutely. So if you want to learn about urology, you can find most of my educational content on the Rena Malik MD podcast or the Rena Malik MD YouTube channel. If you want to see me as a patient, I'm in Southern California, in Beverly Hills and Irvine. Otherwise, any social media platform, you'll find me, Rena Malik MD.
That's awesome. Thank you, Reena.
Thank you.
Thank you for tuning in to The Resilience Factor. If you're ready to build a stronger, longer lasting body, make sure to subscribe and share this episode with someone who's ready to thrive. You can follow me at Dr. Pamela Mehta for more expert tips on strength, recovery, and orthopedic health. Until next time, stay strong, stay smart, and stay resilient.